Perfect. All right. Well, we're going to go ahead and get started. We might have some more join, and that will be great. So, welcome to the July Connections Forum. And you might notice just a little bit of change in this. We used to call this Connections Quality Forum. We are shifting the terminology. We're still going to be doing the same thing. But way back when the HCCN first started, there was a lot more focus in the grant on quality projects. And I'm stretching my memory here. We've had a lot happen since, but in roughly 2012, 2013, we did a project on PCMH transformation across the network. And I'm pretty sure that was part of or tied to the HCCN. And so that's how we kind of started. And now the HCCN grant is very focused on health IT. And while that does have a large element of quality and a big impact on quality, not just clinical quality, but all things quality, we've decided to take that word quality out of the name of the meeting. The Connections Forum is not the Connections Quality Forum because it's more than a quality project or things like that. So we're just kind of changing the name to more reflect what we do in this meeting and broaden it out from that kind of pattern of thinking that we develop in healthcare that, quality equals a clinical project. And so just kind of moving away from that, we have more than just quality in here. We have leadership, we have HIT, which is exactly what we need in the HCCN because there are a lot of elements of health information. And not only that, but we need that HIT piece in all of our clinical quality projects too, just because of how our information is stored. So that's just a little bit of an introduction and why our um, our name has changed. So a little bit of what we're going to do today. My slide will advance. We're going to talk through the activities for the next grant year. We are starting the new grant year August 1st. And so this is what we're going to be doing August 1st, 2026 to July 30th, 31st. I can never remember. 31st, I think, 2027. So basically the next 12 months of stuff. And what I want to do, I really want information and feedback from you guys. On the activities that we're doing, Terry had sent a survey out and all of your feedback was taken into consideration when we built that. And so now that we have the activity sent, I want to make sure that if you have a priority interest under any of the activities, that we know about it. Going to dip a little bit outside of HCCN into the other webinars that we do. And just kind of background information, we have multiple grants we work under. We primarily in this meeting look at the HCCN one, but since we're all together, I just want to check in and see, are there any things that you have that you are going to want me to bring information for, have outside speakers come in for on the quality improvement, the cardiovascular, all of those type of things. So we'll get to that towards the end. And then what's coming up in your health centers? What type of big things are on the roadmap for the next 12 months that might influence what our details are in things that we're coming up on in the next 12 months. And then at the end of that, we're just going to open it up for discussion, kind of like what we do in the quality improvement meeting. We've had several questions come in that I think are probably something that all of you are thinking about, and we'll just get into that discussion back and forth between all of us, whether on microphone or in the chat. So we will go ahead and get into the HCCN grant. So the grant has 6 domains. We added a new one this year. And so last year we had 5. And when I say year, I mean grant year. Last year we had 5, this year we have 6. And these are the domains. We have the data management and analytics domain, interoperability and data sharing, data monetization. This used to be called UDS Plus, but it's more than just UDS Plus. Value-based care, which that's technically in the grant, that's called additional value-based care because built into the required domains is value-based care because that is part of data management, analytics, interoperability, et cetera, et cetera. So value-based care. Health-related needs, also called SDOH. CMS is now calling it upstream drivers of health. Whatever the word of the day is, that's what that domain is around. And then artificial intelligence. So under the first domain, these are some of the activities that we have around data management and analytics, and that's where we put in the work plan for the calls that I do with you guys one-on-one every month. That's where the newsletters are put. That's where the activity on the online HCCN forum. That's where all of that is centered. Your Azara support is in this domain. That includes the one-on-one support that we do on the meetings. That's when any of the support we provide in between times or on request. And we also have the bi-monthly Azara training webinar. There is an additional learning series or learning collaboration this year in this domain, and that is going to be Mastering Data Quality in Drives, and that's a learning collaborative, and we are working with Azara to bring that to the HCCN. We do not have that scheduled, so no, it's not on your calendars because we do not have that yet. We're in the final stages of developing that. And then we also have planned to have some UDS office hours. Anything around these that comes to mind is like, oh, can we make sure this? Or, I didn't know about that. Or can we do something? Can we focus on the report of the month? We did that a couple of years back, and we had the Azara report of the month. Is anything like that that we have done that you liked in the past or that you think would be helpful coming up over the next 12 months? And I am going to stop talking and look at the chat and open the floor.
Amy indicated that Vibrant and Heartland are in Rapid, all capitals for the substance use disorder measure. She'd like a chance to talk about that new measure and the workflow similar to what we've done in the past.
Okay, tell me a little bit more about Rapid. I'm drawing a blank on that. It's Monday, my brain hasn't quite turned all the way on, maybe.
So, pardon me. HRSA provides each year, I believe, or every other year, a chance to
Oh,
involve in
yeah.
Rapid. And there are, I'm sure, other health centers and other measures, but the only other Kansas health center that's in on the initiation and engagement of substance use disorder measure is Vibrant. And, there's the FRN period right now where they're talking about that measure and implications. And we're kind of in we don't know if 30% is good or not. And what do you mean by new episode? So I would really love, since it's a new measure, I know when we've talked about almost like our own version of UDS office hours in the past of, okay, if there's a big change to a measure or a new measure, having the chance to talk about, okay, what does that measure mean to you? And what is the workflow? What are you doing? What have you learned from others? I am trying to learn as fast as I can, but even HRSA in those rapid sessions is saying like, hey, we're still waiting for some additional information on the specifications for this.
And that's something that you're looking for sooner than later, I'm assuming.
Yes, sooner rather than later, or at least like if anybody has had a successful direction, we do SUD at Heartland, but understanding how it's being captured for the measure, I understand some of it. I'm like, oh yes, that's showing up correctly, and others I'm like, where is this coming? Where is this? And so I'd love just to hear how others have been exploring that too.
Okay. First thing that comes to mind, and I'm going to ask the group's permission. What do you guys think about, because I do not have a topic for our next Azara training session, which is next month. Are the rest of you struggling with that? And I'm not saying focus exclusively on Azara, but because that is where some of the reporting is, looking at that, and also talking about how you're doing it in your EHRs. Is that something that you guys would like for the August? I think it's Azara training time spot? I see one thumbs up.
I would be good with it too. There's three votes.
Three thumbs up.
Really, Kimberly said sounds good to her in chat.
All right. Awesome. With that thought of Azara training, and this, it falls under the data management and analytics. Azara does have a lot of the measure of the month stuff. Like every month they have measure of the month that they get into. They have monthly webinars like every week, every other week. Thinking on that, because this kind of brought that to mind to me. Thinking on the Azara measure of the month where they dive into the measure and exactly, and it's more than just here's the numerator, here's the denominator, the exclusions, et cetera, et cetera. It's this is what this is showing, this is where to look for when things aren't looking right. Here's how to dig into it to figure out what you're seeing, compare it with what you have in your EHR, what you should be seeing, et cetera. Would adding that onto the agenda in the Azara section to just pinpoint, would that be helpful? And if so, the one from the month previous that everybody's already seen, or the one in the month that we're meeting that you may or may not have seen yet?
The most recent month, especially diving into, those measures with big denominators, those broad measures, it was really helpful because they started talking about, looking at the run charts, but then getting into some of the other tables and how to filter the denominator out. So, I was not looking at providers with less than 10 patients. That was something I was not familiar with. And so it is helpful, especially with us as we're reintroducing Azara. And there's been a lot since we were last in it.
Okay, awesome. Any other thoughts on Azara training topics? We have 6 of them in the next 12 months. Did you guys like the report of the month where I pulled out a seldom used but kind of interesting Azara report? I see one thumbs up. The breakout reports. Okay.
Mm-hmm. The breakout reports are good.
And for those of you that do not have Azara, I have 2, 3. I have a couple of you guys that don't have Azara. What we can do is at that report that I have out of Azara, that information is coming from the EHR. So that information should also be in your EHR. I think the non-Azara centers are ECW. Maria, do you think we could get together and see if there is an equivalent in ECW for, did Maria leave? No, there she is.
I'm
What do you
here.
think on that? Okay.
There is some quality dashboards if you have them in eClinicalWorks. One of them being the HEDIS dashboard. You do need to make sure that is mapped with your community mappings. But if you have it and you received it, when you received it, they would have helped you out with that. There are some quality dashboards that are available, but some of them come at a cost. So we definitely would need to look to see what your availability is and what that looks like. The HEDIS dashboard, so Dylan, that HEDIS dashboard is customizable. So it's customizable by what you're looking at. So if you don't want all the HEDIS measures, that you don't have to have all the HEDIS measures. If you're only looking for stuff that's like completely up to date, they do have that, but it's what you want. You have to tell them what you want. We do have a health center that has customized theirs by kind of the standard best practices measures. which would be more UDS than anything, but it does incorporate your Medicare stuff, and some asthma things with what your NCOs are looking at. And it's pretty good the way they did it. But yeah, it's definitely customizable with ECW.
Speaking of HEDIS, for the 5 health centers that were originally in the KCN and had a Zara, there is HEDIS in there for the MCOs that we have contracts with KCN for. So that's a little bit outside of HCCN, but since y'all overlap, I did want to just mention that those charter members that also had a Zara when they joined the KCN do have do have access to the MyHeatus and Azara. If there are those of you who really are looking for accurate HEDIS information, and you have the bandwidth for a add-on module in Azara, that is something that is available. The it does the calculated measures from the plan and that type of thing. So that's a side topic, but just wanted to point out that for a few of you, there is some HEDIS available. All right, and this question, give some thought to this, and this might be a leadership question, but we are going to be doing a data quality collaboration with Azara on managing data quality, not just mapping, because it goes way beyond mapping on having accurate and reliable reporting and understanding exactly what you're looking at. As we go through that, there we have had on the agenda for the past year validation, and I'm going to leave that on there, but I want some feedback from you guys. Might reach out to leadership to see what they want. How much support do you guys want in that area? Do you want just to check in? Hey, did you do it? Where are you at? Have any trouble? Or do we want to dive into it and look at it? And that is going to be individual. If you don't want to pop it in the chat, we will talk about that at our next call. But one thing I want to point out, and I have been guilty of this, I have used some confusing terminology. When we do data, we always need to manage all of our data quality, and that is a big thing around consistent documentation, consistent workflows, updated templates, all of those things. And I use the word validation with that, and that's really not what validation is. That's data quality, that's data monitoring. Data validation is really, when I'm talking about that, what I should be saying is measure validation. Because the data that we have in the system, that's separate. We manage the quality of that and the completeness and accuracy of that through our processes, through our documentation expectations and audits and that type of thing. So I am going to shift my terminology because we validate a measure. And that's just a piece of data quality and management. And so I think I might have been using a little misleading terminology just because I hadn't thought through it. So I am going to be changing that term, and that will be changing on the agenda. It had been saying data validation. It's going to shift to measure validation. I do have, for probably half of you, we've worked through a data validation, which will change to measure validation calendar. And we can update that. We can talk about that one-on-one for your individual health center plan around managing your measure validation. And if you catch me saying it wrong, call me out, because that's how we all stay accountable. We keep each other in check. Okay. And maybe I see in chat that you think you're good on measure validation, and having gone through implementation and all of the measure validation involved in that, I would say probably think the same thing as well. Accountability for keeping up to date. Okay, and we will individualize that to each health center. And as we see trends, we'll try and keep those in front of everybody. It's like, hey, check check how you're doing this. We've got some other health centers having trouble with a particular report or filter and that type of thing. Maybe try and
Date
leverage
myself
the
here.
HCCN
I'm gonna date myself, Heather.
online forum a little more.
But in the past, it's been really helpful when like Maria, Heather, Mona, we would share out like, hey, this is a thing we learned, and by fixing this, it changed the measure quite a bit. Those things to go in and double check if anybody finds one and says like, hey, just so you know, this is now this. Those call outs I think have always been helpful too. And I think Dylan, you put stuff in the forum quite frequently that I'm always checking there when, especially when I see it's a Dylan, it's like, okay, there's probably an update I need to go check on. So I think just keeping up with that is also really helpful.
How many of you guys are using the online forum? And you can just do a thumbs up. You don't have to come off of mic. We can use the little pictures for. Okay. Dylan, we know you're using it. Okay. All right. I really like that we have the online forum now, and I really kind of want to encourage everybody to use that, especially for the questions around what are other health centers doing. I am more than happy to, if I have in the recent memory, oh, somebody said something about that earlier, and I can tell you. Happy to ask other clinics when I meet with them. But I really want to encourage when you have a thought, and you're sitting there and you're looking at something, it's like, I wonder how somebody else is doing this. That is perfect for the online forum. Um, Pop it in there because it's asynchronous. You can pop your question in there. Amy sees it and gives her viewpoint. Kimberly gives her viewpoint. Denise is like, oh, I know what I had to do with that measure the last month. And she pops her experience in there. I think that is excellent for what's somebody else doing around this? Or has anybody else fixed this challenge? So just kind of wanted to um, encourage you guys to use that online forum. All right. Any other thoughts, comments, wishes, wants? I better pick it up. We're about 25 minutes in. We got five more topics to cover. All right, interoperability and data sharing. This is the part of the work plan where the HIPAA 1 licenses and the support for HIPAA 1 are put. There are SAFER, that's what they're called. Trish might know what that stands for, but I certainly don't. But really what it is it's like, in addition to the security risk assessment that is required for some places that have Medicare contracts. Trish is going to be the one that can answer, can correct me if I have misrepresented anything. And then we also do the info sharing on interoperability and data sharing, like, hey, this is working, that's not. And one of the things that we are looking at as CCNK, we are going to be looking at finding out from all of you, did you do any work with community-based organizations around data sharing, around interoperability? And if so, did anything work? What didn't work? What were the barriers? To kind of get a feel for what the health IT environment is around information sharing between health centers and community-based organizations. And so that is what we have in the work plan around interoperability and data sharing. Any thoughts on this?
ECW did come out with the new safer guides this year. If you want a copy of those, I do have them, so you don't have to go search for them. If you want to go grab them yourself, they are under the My ECW. Just search safer guides and you'll see the ones that were updated in 2026. There's like 8 of them.
And Trish helped me out here. The SAFER acronym stands for Safety Assurance Factors for EHR Resilience. Thanks, Trish. And you have that is also available from CMS or one of the agencies correct? And you can direct folks to where that is if they need to pull that down.
The forms are available on ONC's website. And like the updates that Maria mentioned in 2025, I believe, um, they did some big updates to those safer guides. They went from essentially 9 domains to 8. So they kind of combined some stuff and they mixed them up and they added new things and some stuff like that. So that's why there's a new version of that available. The safer guides are kind of, do you have these best practices in place sort of a thing? And so I'll put a link to where you can find them um, I just put it under the acronym. You can go out and you can pull those guides down. They're fillable PDFs. But if you have questions about them, the high priority practices in particular is one that if you're participating in, uh, it's not meaningful use. Don't remember what they call it now. Completely blanked on that.
Yep.
But if you're if you're participating, that may be at least that high priority practices may be one that they're looking for you to complete. Hospitals most time had to complete all of them, but I know at one point clinics only needed to do the high priority practices. But those guidelines may have changed. And so, like I said, it's just kind of the thing about the high priority practices is it's sort of a combination of the others. So if you do the high priority practices, it's pulling from the other 7 guides. If you do all 7 of them, I don't know if you would just kind of move your answers into the high priority practice guide. But like I said, it's pulling the high priority practices is actually pulling from the other 7. So it's taking kind of those very really make sure that you've put some thought into this.
Any thoughts on interoperability and data sharing that you guys want us to make sure that we have in mind as we go forward with these activities? Okay, if you're typing something in the chat, keep on typing and pop it in. I don't know if it's supposed to give me the little floating bubbles if somebody's typing or not, but I don't see any. But if you are typing, continue to type and put it in there. And we'll move on to data modernization. This used to be UDS Plus. Now it's called data modernization because it's a little bit more than just UDS Plus. So under this domain for the activities, we are doing a use case forum during one of our connections forums. For those health centers that are in the Rural Health Transformation Project, we will be able to support you in that. We are involved in what we can be involved in learning from the different forums and webinars and teaching elements in the RHTP project and areas. And so we will be able to provide support around that and tech innovations. And then staff here at Community Care Network also participate in the national collaborative of HCCNs. And this is in that that group that did talk about that. And so what we glean from them, we bring back to you. But that's an activity that the staff here at CCNK participate in with other staff of with the staff of other health centers or HCCNs. Gosh, it's Monday and my coffee's definitely not kicked in. I apologize for that. Anything around fire or data modernization that you guys have that you need us to keep in mind as we move forward in the year around data modernization, fire use, um, anything like that. The asterisks that I have on these slides are activities that we are in partnership or have a collaboration going with outside entities. It's not just those of us here in the Connections HCCN.
I am curious to find out how many of us are actually using the Fire plugins. So I know that there's a couple of us using the Azara plugin. I know there's probably a couple of us using the ChartSpan plugin and maybe the Unite Us plugin, but anybody else using any kind of patient application or provider application plugins through their EMR?
In the chat, I see Health Partnership doesn't think so. Hunter thinks they are, but we don't have the right person on. Heartland, the overlays are what they use, and they don't seem to be fire-based. Um, a no from Cowley and Health Ministries. Maybe in the future from Holy Family. I think I got everybody. Always doesn't think they are.
That's good to know, Amy. I did not know that.
Yeah.
I think Blue Cross Blue Shield has their Unite Us, but it's called Find Help. So if anybody's using it, and if it's better than Unite Us, I know that a lot of us have, depending on where we're at. And I know that Vibrant and Mercy and Truth and HPC use Iris, which is not a plugin, but it's the same pretty much program as Unite Us or Find Help. But it seems to be that every payer wants to use their own, which is not helpful. But Iris has gotten great around the Kansas City area. I don't know how it is around the Wichita area. Usually it's pretty good when it comes to larger scale areas, because the more they have in there, the more it works. But it's the same kind of referring type of program. Oh, broader there we go. So that's nice. So it sounds like Find Help might be the way to go. So if you're using Unite Us, you might, and you're not using it to it, the capabilities are limited. It sounds like Find Help might be a better option, but it is a type of fire plugin. So, Amy, do you know if Blue Cross is going to pay that for you, or is that something that you're going to have to?
I think that's part of the discussion right now, is trying to get that, because as you know, the initiation is a little costly, and so is the maintenance cost. So I believe they can help with the initial, like the launch, and then the health center has to do the maintenance, but we'll see.
Gotcha.
Dylan says he'd love to hear how that goes, and I imagine there's additional health centers out there that would be interested. I'm going to put that as a side note to make sure that when we do this Connections Forum, that we make sure and have some member spotlights, or maybe we can get Blue Cross on to talk a little bit about it. I don't know. See what we can do around that, because that kind of covers both of them. While I mentioned that, as we go through the next 6 months, or I mean, 6 Connections Forums over the next 12 months, what we are looking at doing is doing one connections forum for each of the domains. And so that'll kind of be the progression of how we do that. So I am going to make a note of that here. And that is okay. Any other thoughts, comments on interoperability and data sharing? Or
One
no?
of the things this is Trish. One of the things I was going to mention is that Fire was designed, for those of you who've been in computers or in IT stuff for a while, we used to call it plug and play. And so, like, for example, when you had a keyboard that had the little round purple connection, you plugged it into your computer and it just worked. Like, you didn't have to do drivers, you didn't have to do anything special really. You just plugged it in and it worked. So it was plug and play. Um, Fire is essentially supposed to be plug and play because what it is intended to do is to say this information in this place in this system, matches up to this list, for first name, last name, insurance, whatever the case may be. And in this system, then these mapped data elements go here. So they're not supposed to require like the same level of implementation as say an HL7 interface. Um, Obviously, I'm assuming there would be some validation to make sure that everything is indeed flowing where it is supposed to. But it's supposed to be relatively seamless. And so I would be really curious as you all do start work with Fire or the things that you've done so far with Fire, has it been even somewhat seamless, or is it still there's a lot of work to get the setup? So when you, like I said, when you guys start working on that, if you can kind of send me just some ideas. And Dylan said that maybe some EHR specific work groups could be helpful. Um, they like, for example, eClinicalWorks does not have the same tendency to accept data into the EHR that some of the others seem to do a better job of. Because I know that's always one of my questions when anybody talks about, especially with eClinicalWorks. Um, Phreesia, for example, was one of the things that I think when Callie was implementing, Phreesia has said, "Oh yes, absolutely, we can, put information, demographics, whatever, into your EHR," and that was not the case. Like it was still kind of a PDF document and it wasn't super usable. Um, and so, like I said, I know sometimes there is a difference in what EHRs will accept into them and how it accepts data into them for good reason, because you don't want bad information coming into your EHR. So I understand it at that level, but we'll make a note of that, Dylan, as far as the EHR specific work groups.
We are actually working on EHR specific work groups. We just have not completed it yet. So it is coming in the future. It's just a little bit away for right now, but we're working on it.
In the meantime, leveraging the online forums would be a good spot to do EHR specific questions. Especially for the ECW users. The Athena and NextGen users, there's two each of y'all. And I know that sometimes you just email each other. So whichever works the best. And sometimes finding out what a different EHR is doing can be helpful. Sometimes it just makes you, oh, I wish mine did that. So whichever works the best for y'all. Any other thoughts on this before we go to back my slides up somehow?
I think you did by a slide because I think if you go forward, weren't we on data? Yeah.
I thought so, and then I looked up
Yep.
my slides and I'm like, wait a minute, and I have some reply started. I think I put something on the keyboard because I have a reply to somebody's chat and it's like, that's not even English. So I apologize for that, guys. We will move on to value-based care.
Wait, I want to give one thing on that slide. So you'll see where it says at the bottom, participate in and share info from national collaboratives. So Heather, I, and Trish, we do this, and Terry do this at the PCA level and the HCCN level. I did want to share one bit of information that I found out that was very interesting. If you use LabCorp, we are not talking about Quest. Quest has a green light. LabCorp, if you use LabCorp and you are using the swab that allows your female patients to self-swab for HPV, that LOINC code is not a part of the value set for the cervical cancer screening. Now, what I have found out is that it will be before the end of the year. But for right now, you should not be seeing any of those qualify for that quality measure. Just be aware, because that right now, the LOINC code that is attached to that is not applicable to the value set authority. It will be, but if you use Quest, theirs is. So Quest, you're good. If you're using Quest, you are good to go. If you're using LabCorp, you're just gonna have to wait a little bit, but they will not qualify as of now for that cervical cancer quality measure. Okay, Dylan, if you are, so if your primary lab is LabCorp, the self-swab, I had the lab number, and it is a HPV self-swab for LabCorp. I'll look for that number when we move on. But it does not qualify for the cervical cancer screening measure for the HPV. Does not. That is because the LOINC code that is attached to that is not a part of the value set authority. But what I did find out is the value set authority is not up to date. So they're saying that that LOINC code will be a part of that measure and qualify by the end of the year. It is just not correct yet. It's not updated yet. So if you use LabCorp, the self-swab for HPV does not at this time qualify for the cervical cancer screening measure.
And really what's going on is just more things are getting approved through FDA. Like we have a new whatever. There's additional types of swabs now. They're approved, they've gone through, they've gotten their LOINC code, but the data specifications haven't been updated yet. So they just lag a little bit behind. So that's all that's going on. And they will get that data set updated. So like Maria said, it's coming. It's just not reporting the way it will report once they update that measure set. But keep in mind, until that measure set is updated, that is not qualifier for the numerator because the specifications in that data set are what has to be reported on. Some of you may remember back a while ago, and this was pre-COVID or right in the beginning of it, but the adult BMI measure, it had they worded it wrong. And they worded it wrong in the specifications such that we had to report it the way the data set was because the data set was written separately from the narrative piece of that because there's two different pieces. There's the part that you read, and then there's the part that the data engineers have to use. And in that, instead of it being, you had your BMI, your adult BMI was measured, it was out of range, and you provided counseling. The way it is right now, the way it was before this error that lasted 3 years, it was any time in the year. During that 3-year period where there was an error, it was on that date or later. Ones you did earlier in the year didn't count. And so because that's the way the data elements were written in the ECQM for the data engineers, that was how it had to be reported because it has to report exactly on what is in the measure stewards, the ECQM specifications. So it's wrong in that it's not fully inclusive, but we have to report it that way because we have to report the way the measure steward has the ECQM written. Now we're expecting them to update that, and then it will all just settle out in the end. But just to split those hairs for some of you data people that like to split those hairs like I do, just wanted to put that out there and a little bit of a historical example. And yeah, that adult BMI measure really stunk for about 3 years. And they said, no, we're not going to go back and fix it. It'll be fixed in whatever year it was because they put those out ahead of time. And it's like, thanks. But then we got distracted by COVID, and so it really wasn't a priority anymore. All right, moving on to value-based care. What we have in our, oh, all right, I'm going to take my hand off the mouse and leave it alone. What we have in our work plan is that as you have a need and your health center or you have a desire for any custom scorecards or dashboards, we will work with you to create those. Y'all know me, I will probably play with one and have it out there whether you ask me for it or not. But if you have we want to look at this, these measures on a scorecard, or we want you to put these measures on a dashboard with these filters, or et cetera, et cetera. We have that in our work plan. We will support any of your use with your data management and measure validation. Maria can speak to this, but there's a coding data dictionary in the works. And then if you have a need for some more information on value-based care directly between your health center and us, we can provide some of that support as well. Maria, do you want to say anything about the data dictionary that's in the upcoming work plan?
That data dictionary is to help everybody, regardless if you're in the CIN or not. If you're an Alidate, I'm hoping it'll work. We are going to split up the CPT2 codes, so those value-based care codes, into ones that qualify for Medicaid and the ones that qualified for Medicare. We're going to split those up so you'll know which is for which. We're also doing LOINC code dictionaries, and that would be for all the panel and the exclusive tests. So adding LOINC codes to your labs or procedures or whatnot will not be as hard because that gets a little confusing. There'll be some SNOMED code stuff in there and some SNODENT stuff in there. Don't forget about dental. Also, I'm probably going to include condition codes. A lot of us forget that we can map some stuff in dental on condition codes. And so if you have a robust dental team like Kanza or like Heartland that rely on a lot of reporting, and your staff is very functional with your dental staff is very functional with that. We're going to try to kind of give them some help also on the dental side with SNODENT and CPT2 codes. There's not really any CPT2 codes, obviously, for dental. It's because they're on CDT codes. But there's some help that we can get on that side. I'm hoping to have it done sometime around conference. But I say that, and every time I say that, something comes up and I never get it done. So I am working on it, I promise.
Is there anything around value-based care that you have on your roadmap that you know you're going to be doing or needing some information around? Any thoughts on where you're at with value-based care support that you would like us to keep in mind as we go forward? And don't think that it's just going to be your health center, because when you guys mention something, there's other health centers that are like, because I hear it later, it's like, yeah, I'm glad they said that because I didn't think of this, or yeah, we got that going on too. So don't think it's just you. Your ideas help really inform the rest of the network, what their kind of things they have in mind and things they may not have thought of yet. You broke your CRE. That's that's no fun.
This is why Heartland can't have nice things. We started with CRE and put like 50 things in there, and then all of a sudden, our blood pressure. This person has
Is
a below 80 diastolic, but also an above 90
yeah.
diastolic, and they have all of the depression scores.
So
Oh,
FYI, if you are an ECW and you do the CRE, I always start with blood pressure, right? One, because it's the easiest one to do, pretty much. Two, because it's the easiest one for the providers to just look at and know what it's talking about. Also, it's because it's the one that breaks. And if it breaks, it is a ticket with ECW, because it's something
Oh,
on the
okay.
back end that has to work. So if you have it set correctly. Um, if you have it set correctly and it's dropping multiple like systolic or multiple diastolic codes, put a ticket in with ECW because they have to fix it on the back end.
Thank you, Maria.
Mm-hmm.
and if you're wondering what the CRE codes have to do with value-based care, keep in mind that under your value-based care contracts with your payer, they only see the stuff that's coded. So by sending these blood pressure codes on the claim with the CRE dropping the codes in for what their blood pressure values were, the MCO or your payer contract that's other than an MCO, they're seeing your performance in that hypertension area and whichever other areas you're dropping those codes on. And so they have that data, they have that information. It'll cut down, I hope, I think this is the intent of it anyway. They'll cut down on the records requests for HEDIS that you guys get because they already have it.
We're trying
Plus
to
some of those
eliminate all the
sunflowers.
CPT codes.
Yep, and Sunflower has the incentive program going on, so know that that is. Kim asked, "How do we get the repeat blood pressure CPT2 codes to drop?" Kim, I'm FYI, you can only claim out one blood pressure. So if you have an orthostatic or if you have a repeat blood pressure, you're always going to take the last blood pressure, so it's the most current. So whatever one was done at the last, those are the codes that are going to drop. ECW will only drop the most recent. So like I said, if it's depending on in your system how you're reporting that, it is going to be the top number, the most current number. That's what it's going to do. If it's a repeat, you can't have more than one systolic or more than one diastolic code. It is only dropping the first number. I have a question, Kim. So is it when you're entering that blood pressure, are you entering it manually or do you have the pop out? So if you have that pop-up box checked where you can add multiple, or are you just adding multiple to the window itself? If it's the pop-up's going to drop it in order. If you're just adding an additional blood pressure to the window, I always recommend if you're going to add more than one of anything, you have that pop-up box out because, like I said, the system will drop it the way the way it's concurrently supposed to go. Where if you add it to the box, I think it'll always be the first one. So just know that. So it's probably because it's not dropping concurrently with what is supposed to go first. Like I said, with the pop-up box, it'll drop it in order of it if it was received, but the other way will not. Yeah.
Health Partnership had a glitch in their CRE around BMI on pregnant patients. Anybody else have anything like that going on that did the 12.0.3 ECW upgrade patch, whatever those are called?
You can skip the pregnant people on the BMI. So remember when you build those, um, you would have to exclude anybody with a pregnancy assessment code, which would be difficult, but that's what you would in the CRE when you build the adult BMI, because you're building it by age, you would have to exclude all the people that are assessed as pregnant.
I mean, what I'm hearing is you have poor patients who are still pregnant a year later.
I have been pregnant approximately 4 years, but not literally, but the EHR thinks I've been pregnant for 4 years.
Yeah. And that's something to keep in mind for everybody. If you have a patient coded in your diagnosis codes as pregnant, that does need to be resolved at the end of that pregnancy because it's going to impact your UDS in that there are exclusions for pregnant people in some of those measures. So, that could be something that's like, why isn't this person on this list? They should be. It's like, well, they have a unresolved pregnancy from 4 years ago, so they are being excluded from the whatever measure. All right. Okay. Any other points around value-based care you want us to keep in mind as we go through the next year? This practices around.
Managing the problem list is a great one. Dylan said that, and that's hard because of providers, right? You know what drives me, it used to drive me nuts, is that a well child visit Z00.129 or Z00.00 should not be in the problem list. That is not a problem. That is a well visit. But it happens, right? And it used to drive me nuts. But I couldn't do anything because if I tried to do it, then it would put my name on the back end as diagnosing the patient with it. And so also if you have any 9 codes that need to turn into 10 codes, because regardless of what EMR you have, the EMR was out before we went to ICD-10 codes. So a lot of us still have those 9 codes in the problem list. The problem with that is that the provider has to have the due diligence to change them on their own. We as nursing staff or as quality and HIT staff, we can't do that because it will put our names on the back end of it as we diagnosed. So, how do you get your providers to take the time to do that? And it's just something that has to get done. It takes 2 seconds. The tool in ECW is in the patient hub under PL 9 to 10. It's very easy to do. But Dylan's right. How do you get the problem list managed? That's great.
That is awesome. Thank you for that topic. All right.
Wow, one person with
Yeah.
11 types of diabetes.
It's there.
It does.
It's there. Multiple
Yeah.
versions of unspecifieds, but also very specified.
All right, let's take a look at the next domain, health-related needs, which is the name of the old SDOH, and the new terminology coming from CMS is upstream drivers of health. And we are doing a learning collaborative, upstream drivers of health, and that is going to be joint with the HCCN grant and the PCA grant, so that'll be open to everybody in the network. So these are the topics that are going to be in that collaborative. Another thing that we are doing under this domain is the risk algorithm update. We are looking at doing a focus group to kind of drill down into that, and we do have those of you that volunteered for that already. We have you on a list. If you would also like to be on the list, let us know. One thing I do want to make sure that what the risk algorithm is it's not grading your patient's complexity. It is intended to be a way to focus your efforts, and this is kind of with a value-based care mindset, but focus your efforts on the patients you can most impact through more intense management. It is not is this patient a high needs patient, a high complexity patient, etc. It's is this a patient we can impact highly? And what we have going on in there right now is there are way too many people in that high risk group. It's not doing what it is designed and intended to do, which is to stratify that top layer, those high risk, at roughly 5% of your patient population. And so going to be looking at those calculations. The underlying algorithm of the risk assignment scores is based on a standardized algorithm, and that is not what we're looking at changing. Once we have all that done, we will have a training webinar on what was changed and how to use the risk algorithm. So, okay. Dylan, yes, I am pretty sure your name is on the list for the focus group. We will be having one from each of the EHR systems but it is going to be a focus group, so it's not everybody in the network. So if you're not in the focus group and you want to provide some input, you can provide that to any one of us, or you can let me know on our calls. But that is not starting yet. We will let you know when we do get that. And the focus group time will be planned with the attendees. We'll do the little doodle thing to figure out when we can all meet. And then we also, under health-related needs, have the Outpace CBD program, which is, we will be supporting that implementation in your health centers. What that really is, it sounds like a whole big thing, but the American Heart Association has the Outpace CBD program, which is kind of outlined how to put into place all the new things around cardiovascular health in the updates and the implementation guides and the recommendations and such. So that's what that is, what that one is, and that is in partnership with the American Heart Association. Any thoughts on this? Amy, I see your comment about using it to as a way to identify care management referrals, and that is exactly the intent of that risk algorithm, is to identify those that would benefit from care management. Any thoughts around what you might have going on in the health-related needs SDOH upstream drivers of health space? Get them on time. Billing. How are people billing for that? That sounds like, Maria, that sounds like your question.
We're talking care management. How it is it? Oh, workflows. So, with care management, SDOH. So a lot of them are doing, they have like Heartland does, a robust CHW program. So a lot of people are billing your prepare form out through the CHWs because that's a required part of their workflow. Remember, Medicare doesn't pay for the upstream drivers of health assessment anymore. That code is not for that. That was the G0136. So most, I would say, are billing it out through CHW work.
Any other thoughts on the oh, Maria, say that code one
So
more
it's
time.
no, that's fine. It is billed out through CHWs. So your community health workers. So if you have community health workers that are not billing, but they're doing the work, right? We want them to bill because it will get reimbursed. The Heartland Conference, this is through Mid-America Regional Council in Kansas City. It is in September. If you have a group of CHWs, okay, if you have a group of CHWs and they are not billing and they would love to know how, we have and I think the staff from Heartland, Amy's Heartland, is also going to be there because they have an amazing program. And the Heartland Conference is through Mid-America Regional Council. It is in September. I believe it's like the 8th. And there is going to be, I believe it's a 2, 3, 4 hour CHW. I will be there for that. So will Treva from our team, who is also a CHW. But there's going to be a big session there for their conference. If you need any information on that, please go to Mid-America Regional Council's website, search for the Heartland Conference. That's where you'll find all that stuff. And see if you can only, if they only want to do it one day, you can do it for one day. But we have KDHE and CCNK and Mark have monthly calls with the direct through for Kansas with CHW directors and CHWs for themselves to do workflows and to do reimbursement management and all that good stuff. So if your CHWs are not on these calls, please let me know. We can get them on them, or they can reference the KDHE CHW cohort for the state of Kansas. The coalition, they're great. You can get on those webinars through and those meetings through their website.
That's wonderful. Thank you for all of that.
That's my plug.
You've done that once or twice. All right. If you are typing something into the chat, go ahead and continue on that. If you have any other thoughts around health-related needs, let us know. And we will move on to artificial intelligence domain. So in this one, the activities that we have are a learning series around safe use of AI, AI governance and safeguards, and AI impact and use cases. So that is what we have. That is the new one for this year. So it's really going to kind of be exploring and some baseline learning around AI in overall, not like this specific tool or that specific tool. If you guys have specific tools that you're using or that you have used or that you've trialed, we will be talking with you about those, seeing, trying to share that across the network so that we don't have one health center trying something out and it didn't work, and then the next health center, a couple of months later, another one's tried it and didn't like it, and another one's tried it and didn't like it. That's kind of what we had when Frisia was going through the state. We had a health center would start it, and then 6 months later, another one would start it, but the first one had dumped it and kind of was like a revolving door. It's like, all right, who's in Frisia now and who quit? So just trying to kind of facilitate what you guys are trying and what you're finding and what is going on around it, because what doesn't work for one health center might work for another. Case in point, Frisia. For the ECW health centers, it was bringing a PDF in. They've told us, I mean, the whole time I've been here at Community Care, Frisia has said, yeah, we're going to put it in as discrete data, and it's not happening. But at in NextGen, it was very effective, worked very well. And when NextGen moved from Frisia to Luma, the it wasn't as well liked. And so just kind of what works in one EHR might not work in another. And same for the way one health center is using it versus another health center. So just kind of getting not so much a thumbs up, thumbs down, but a here is what we experienced in the tool and in our use of the tool. So that is kind of what we are looking at around artificial intelligence. Amy, you have been busy working with Suno for everybody. Trish has a question for those of you using AI or scribes, AI scribes. Do you or how do you obtain patient consent? Or do you obtain patient consent? And if so, how? Uh, Hilo has it automatically.
Amy, I'm guessing. So when I say automatic, this is
Yeah.
what we do.
Verbally in the
Usually
visit.
with Hilo's gonna have an automatic consent that has to be used. It's defaulted in ECW, but you can change it, you can alter it, modify it, whatever you want, but it is a requirement. So everybody that uses Hilo is gonna have that consent, just like they would with the patient portal in the beginning.
All right. Looks like similar processes, but yes, that's excellent. Thank you, everybody, for sharing that. Any thoughts around what you guys are looking for as far as AI within the HCCN work plan?
I am curious. And if you didn't go to ECW Day, it was in Kansas City last week, it's in Wichita this week. They tell you all about the new and improved stuff. Some things you like and some things you just don't listen to. But I'm very curious and I would love to know if anybody is using or thinking about going to Genie for ECW. There is some amazing things that it can do, especially when it comes to efficiencies and costs. And I'm just curious on if anybody's thinking about going to any part of Genie, whether that be, after hours calling because it can do that. It can, where are you starting? What do you think? I'm just curious because I would love to be in the nitty gritty with somebody who's implementing that.
So we do have a health center doing that. And I've already warned them that I'm going to keep checking in. They're in the exploration of it, of how do we want to do this phase. And they've agreed that once they kind of have gotten in there, tried it, and have an idea of what's going on with it, that they will come and do a spotlight at one of our quality forums.
What part though? That's my curiosity. I want to know what part they're doing of Genie.
They're exploring. They haven't picked,
Gotcha.
but ooh, AI phone system. And I'm kind of holding the name because I don't want everybody to bombard with questions about that, but if you throw your questions around that in the online forum, I will definitely reach out and make sure that this person responds. So I try and kind of put a little bit of I don't want y'all getting overwhelmed, so I try not to throw out any identifying stuff unless you've told me it's okay or you're on the call. So, and that's more so to keep any one individual from getting half a dozen emails from it's like, what is going on? So, just know that I do that just kind of to keep the relationships open. So it's like, I don't want you guys not to tell me kind of what's going on in your health center because you're afraid I'm going to tell somebody else you're going to get 16 different emails. But also I want to facilitate that as well. So we do have a health center that's getting ready to use it. I will talk to them and see where they are, what steps they're taking and what they would like to share. And then you'll know who it is at that point. So I hope that makes sense why I do what I do the way I do it. And if I get feedback from a bunch of you that you want it done a different way, absolutely I will. So we are getting close to the end of time. So I'm going to skip this because this is not an HCCN question, but I want to get to what is going on in your health centers in the next year, what's kind of on your roadmap that you're getting ready to move into that relates to any of the HCCN domains. And we won't make you do a spotlight if you don't want to. But I might pick your brain and then spotlight for you. We've done that a few times too. So what do you have on your roadmap coming up in the next 12 months? That's in data analytics, data usage, um, interoperability, value-based care, health-related needs, AI. And if you're not sure what's on your roadmap, or you don't have a map, you just kind of finding your way, check, let me know. This is just more so that we can make sure that we are ready to support your health center. Two-way texting and AI enhanced online scheduling. Those all sound really great. Melody, I was just thinking the other day about Athena and when we went when we implemented Athena like 3 months before COVID, December 2nd or something like that, 2019. We had an option to do like it wouldn't change it on the schedule, but it would look at this patient. Do they no-show a lot? Do they never no-show to kind of look and kind of facilitate, should we double book this spot because 4 times out of 5 this patient doesn't show up, sort of a thing. Is that still something that Athena does? Is that anything that you've tried? I was just thinking about that the other day.
Athena does track based on if that patient doesn't show, we enter a reason. So if we put does not show, it will tally that, or if they late cancel, it will keep track of that as well. We don't typically double book, even if that patient has no showed frequently. We have our internal policy that says if they've no showed 3 times, then they're moved to same day scheduling, as long as they're an adult. I'm sorry, 18 and above, 3 no shows, same day schedule.
Thank you for that.
Of course.
Trying to write down some of this stuff. I was going to snip some of these, but my snipping tool is hidden behind one of these windows. Trish, are you grabbing the stuff out of chat?
Yes, ma'am.
Awesome. I'm going to quit trying to write down everything everybody's putting in there. This is awesome. Thank you so much for this feedback. Let's see, we have about 5 minutes left. Wait a minute, where did my, come back here. All right, what have I done? I broke it. I'm going to pop back to the webinar one. Are there specific topics that you want me to make sure and bring to the cardiovascular groups? There are two, one's more so theory, one's let's put this into place. So those are going to alternate on the different months. We've got the quality improvement one. What I'm looking at doing in that is, hey, what have you been doing? What do you got questions on? What worked? What are you seeing? Kind of more of a getting more engagement between the health centers and information sharing and kind of live brainstorming or somebody used a word the other day that I really workshopping it. So, you got a problem going on and bring it and we can workshop it in quality improvement webinar with all the other minds and get the hive mind going. And then of course the Zara training and the connections forum will be going on. So any thoughts around cardiovascular stuff? And let me throw this question out. I haven't done a whole lot around diabetes in the last couple of years. I mean, we kind of touch on it with cardiovascular sometimes, but is there a want, desire, need for more around diabetes? I don't want to neglect that, but I know for a long time we focused on diabetes and kind of like the first year I was here and before I came here, we had a lot of things around diabetes. And then it kind of shifted over to cardiovascular. We've had the new guideline updates and changes. We've got the new CKM implementation manual. NAC has a diabetes guide and a cardiovascular guide. They've got additional ones, but I don't remember what those are. So we've got a lot of resources around cardiovascular, so that's why I was sticking with cardiovascular. Tell me if I need to shift or add anything into.
Heather, Amy made a note in chat that she has some big med dental integration stuff that she'd like to share because they're expanding perio intervention for diabetes based on results of improved A1C and consistent A1C testing. Kimberly said that she would love to discuss medical dental ideas as well.
Awesome.
And Melissa mentioned all the grants around nutrition therapy.
I love those ideas. And I think they fit with this group of topics I'm talking about, the cardiovascular quality improvement, et cetera. Those are non-HCCN spaces that those are supported out of. I don't expect you guys to remember which grant does which, but with HCCN that is an exclusive, it's an exclusive club. So I think these we definitely want to pull into this space here that is up on this this slide for the those type of webinars for the nutrition and the med dent and the diabetes stuff that you got going on. Awesome. These are great ideas. Thank you. Any other ideas that I don't even have up on the screen that I haven't even thought of yet? Well, I hugely appreciate everybody coming and engaging and sharing. This is great. I was a little bit nervous because it's like, oh, I got 90 minutes to fill. I need to put stuff in here, but we filled it with pretty much the HCCN work plan. I had in my back pocket some questions we've been getting across the network to ask in case we ran out of time and didn't even need it. So thank you so much for your input and your information so that we can make sure that what we're doing is what you need. So thank you, everybody. If you think of something after the call, send an email, send me a text, send me a Teams, give me a call. Whatever it is, we really want to know what you're thinking and what you need. And I'm not going over time today. So thank you all. I'll give you back 2 minutes. Where is